Hello everyone. So let's start our next video, which is fifth in the series. Uh, Now, as time is less, we will focus more on some topics. Okay, some specific questions more, and the other question we will cover uh, superficially. So let's start without wasting any time. So our next question is male 30-year-old noted growing finger, facial skull, then changed face, complaints of poor eyesight, weakness, skin darkening, loss of body weight, X-ray shows broadening of cellular tarsica, thinning of tuberculin sphenoid, signs of increased intracranial pressure. So now quickly take the keywords. Okay, growing fingers, facial skull, changed face. This is our first one. Then skin darkening. Okay, then broadening of cellular tarsica is another one. Thinning of tuberculin sphenoid also, and increased intracranial pressure. So first hint is here increase intracranial pressure, but there is no history of injury, so we can suspect something inside the brain which is causing the pressure increasement. So what we suspect here? We suspect here any tumor that is compressing the parenchyma and increasing the pressure. Okay. Now see the symptoms: growing fingers, facial skull change face. Uh, in this age, 30-year-old, you shouldn't have growing fingers or skull grow or facial bones growth. Okay, so these are abnormal. So what happened here? There is, we can suspect there is abnormal hormone, right? Which hormone? Our growth hormone. So abnormal growth hormone, if it increase by something, it will cause growth of fingers and facial anything which not the long bones. Okay, it cannot affect the long bones, so fingers, facial skulls, faces, face bones, this will grow. And also there is one hint that broadening of cellular tarsica, so we can suspect that the tumor is in cellular tarsica. Okay, so from this we can suspect like our straightforward answer here. It is adenoma of hypophysis. It is the pituitary, and cellular tarsica is that place only. Okay, so adenoma, tumor of hypophysis, and we'll have, for that we'll have growth hormone increase and resulting growth finger, facial skull, chest face. But we can add something extra like growth hormone increase, like increased growth hormone. There are two conditions. Okay, increase growth hormone. There are two conditions. First one is, and what about the diagnosis of this disease? Okay, let's first complete it. So we have two diseases: acromegaly, and second one is gigantism. So what are the differences? Both are caused by increased growth hormone. The main difference is onset. Acromegaly onset adult. Okay, 20 to 40 years old. Gigantism child before the closure of growth plate. Okay, so what will be the differences? In acromegaly, adult onset, so already the growth plate are closed, so there will be no increase in height, so only increasement of some specific areas like lips, tongue, jaw, then fingers, feet, like this. And in gigantism there will be increase of height also, increase of height, so there will be increasement proportional increasement, and here it is disproportional. Disproportional increasement. Okay, so here height not affected, puberty not affected, gonadal development not affected cause these things already developed, okay, but here height is increased, puberty time is delayed, and gonadal development also delayed, okay. So these are the difference. So now in this question, what is our diagnosis? You have the male of 30 year of age, growing finger, facial and changed face. Nothing about height also. It is sure shot or acromegaly. Okay. Next question. A patient complains of a tormental agonizing cough with expectoration up to 600 milliliter daily, purulent chocolate color sputum with a decay smell. Onset of illness was abrupt. Temperature 39. Fever with irregular type. There is the area of darkening with a cavity in the center of X-ray film with irregular counters and level of liquid. What this is the question. So first one is tormental agonizing cough. Okay. Then expectorant. Okay. Onset abrupt. Temperature 39. Chocolate color purulent sputum. Area of darkening with a cavity in a center on X-ray film. Okay. With irregular counters. Okay. So we can exclude something, right? So lobar pneumonia, we don't have cavity. Pneumonia complicated by abscess. We can have cavity. Bronchiectasis illness, no cavity. Tuberculosis, no cavity. Gangrene of lung, cavity can be. Okay. So we need to differentiate about these two, gangrene and abscess. Okay. So what is the difference between gangrene and abscess? We both can have cavity. Okay. So the difference here will be the counters. Okay. So in abscess you will have regular counter. Okay. In gangrene you will have irregular counter without any specific boundaries. Okay. It will be more spread. And second one is the type of pain. So it is tormental, like agonizing pain. Okay. Agonizing cough, agonizing pain, because the gangrene is a destructive process. So it will it will suffer the patient more. Okay. So first one is the border irregular counter and second one is agonizing cough. So these two help us to diagnose that it is a gangrene of lung. Then a 24-year-old patient complains of nausea, vomiting, headache, shortness of breath. He had a he had an acute nephritis being 10-year old. Proteinuria was found in urine. Objectively, skin gray pale, edema not present, extent of second tone above aorta, BP 140 by 100 to 180 by 100, blood level of residual nitrogen 6.6, creatinine 406, daily diuresis 2300, nocturia, specific density 1009, albumin 0.9, WBC 022, RBC single, highly inconsistent single specimen. Okay. So which are the things we need to know? First, there is one option, that is pheochromocytoma. So you should know in pheochromocytoma. So let's first about the symptoms: nausea, vomiting, headache, shortness of breath, and history of acute nephritis. 10 years. Proteinuria was found that time. So nephritic syndrome, nephritis, it will be proteinuria can be there will be must. Okay. Objectively, skin gray pale, edema, accent, BP, blood residual, creatinine, triple diuresis. Okay. So here we need to know about some disease. Okay. So pheochromocytoma. In pheochromocytoma, what happens? Pheochromocytoma, there will be triad. some triad. What are the triads? That is episodic headache, then profuse sweating, and there will be tachy. So nothing is here, okay, only we can see headache, okay, no history of sweating or tachy, so we can exclude this. Then here albumin is 0.9, right? Albumin is 0.9. So nephrotic syndrome, the criteria is albumin should be more than 3, but here is 0.9. So this can be your answer also. In stenosis of kidney, what happened? The renal artery gets stenosed and sudden shootout of BP occurs. So here no history of sudden shootout of BP. It is average 140 by 100 to 180 by 100. So stenosis of kidney, no. But there is history of acute nephritis. So you can suspect that 10 years ago, 10 years old. So now 24. So it can be a chronic nephritis. So chronic nephritis with violation of kidney function. As we can see, the creatinine is high, right? The creatinine is high. Normally it's 60 to 105 millimole per liter. So it's 406. It is high. So we have the kidney function disorder, and other things are normal. Urea it's 2.5 to 10.7. So it's normal. Daily diuresis is normal. All other things are normal. So you have a history of acute nephritis which converted into chronic one, and then we have creatinine high. So there is chronic nephritis with violation of kidney function. Next, a 33-year-old male patient was admitted to a hospital. The patient is pale. The patient is pale and attempt to stand up. He complains of strong dizziness. There is a vomiting like coffee ground. This one most important word. Approximately an hour ago, BP 90 by 60, pulse 120. In anamnesis, the patient has suffered from ulcer of the stomach. Already given. The diagnosis is already given, right? Painless from during 4 year and ulcer was exposed at gastrofibroscopy. So we have a history of ulcer. So there is the diagnosis and there is coffee ground, vomiting, and BP is 90 by 60. So 90 by 60, it is normal or low? It's low, right? So there is hypotension, or you can say loss of volume. You can say anything. So why this is happening? This is happening because the perforation of ulcer, which is leads to bleeding, and this you can see by the coffee ground appearance in vomiting. So coffee ground appearance in vomiting gives like we can suspect it as bleeding from the stomach ulcer. So this straightforward answer, ulcer of stomach complicated with bleeding, but it can't be this easy, right? Also, so we need to know about the things which is complicated. So first one is stomach ulcer, and second one is duodenum ulcer. So if they didn't give you the diagnosis of stomach ulcer, how will you diagnose it? Okay, so there are some specification both ulcer. So first one, like stomach ulcer, so you will have ulcer in that area, okay, and in duodenum you all know. Sorry for my drawing again. So post this part. Okay, then so means in stomach ulcer the pain is immediately after food. It can be 30 minutes to 1.5 hour after meal, post meal. Here what happens in duodenum ulcer, the pain is usually later. So it's about 2 to 4 hours post meal. Why this happens? As you are aware of the anatomy, like when the food comes down to esophagus, it takes a very little time. So within few minutes it comes to stomach, and in stomach it increases the acidity. So here the food comes first in stomach, so we'll get the pain here first, okay, within 30 to 1.5 hour. But in duodenum it reaches after 2 to 4 hours, and also when the food is there, acids also reach there with the food, so it increases the pain. What else? It is associated with hematemesis. As you saw in our question, coffee ground vomiting, vomit. In duodenal ulcer, we see mainly melena, so blood in stool, right? As this is late occurring after 4, so this can be occur in night. You can see the like you can see patient complaining about night pain, and they are getting awakened by the pain like this. This can be malignant. These have less chance of malignancy. Okay, so these are the differences you should remember. Next one is 48-year-old patient complains of heaviness in the right hypochondrium, itching. So we'll take first. Okay, heaviness in the right hypochondrium, itching. Okay, he has been treated with infectious disease hospital repeatedly due to icterus and itch on physiologism, meteorism, ascites, dilation of abdominal wall veins, protruded umbilicus, splenomegaly. So this is a very specific science. Okay, very specific science. You should diagnose it within seconds. So this is a your short answer of liver cirrhosis. Okay, why? You don't need to look about these things, okay, because you have to remember the signs of liver cirrhosis. What are these? First one is, in liver cirrhosis you get the liver is damaged, so there is portal hypertension, and this leads to ascites. There is spider angioma, sorry, spider angioma. There can be encephalopathy. There is itching and red bumps. Okay, so you can see ascites here, you can see dilation of abdominal veins, protruded umbilicus, itching. So these all are indication of liver cirrhosis. Okay, all these things are like gallstones is not related to that. Viral hepatitis, you will have fever, history of fever. Cancer of head of pancreas, it will have pancreatic enzyme problems, and cancer of liver. I don't think like cancer of liver will not give you this type of symptoms. Okay, so you will have anorexia like that also, non-specific symptoms. So next one, a 25-year-old man has facial edema, moderate back pains, temperature 37. So here important is we have facial edema, back pains, temperature is 37.5, BP 180 by 100, hematuria, proteinuria, hyaline cast. Sorry, facial edema, hematuria, proteinuria, and hyaline cast, and it is connected with acute tonsillitis. So history of acute tonsillitis 2 weeks ago. So these all options are kidney problem where we can have hematuria and proteinuria, but there is some specific things like in case of BP, temperature is normal and acute tonsillitis. So first of all, we need to know about the difference between two most important things, that is glomerulonephritis and pyelonephritis. So we will see this first. So first thing is glomerulonephritis, and second one is pyelonephritis. What is the difference? As the name suggests, it is the inflammation of glomerular apparatus, okay, glomerular membranes, and it is pyelonephritis. It is the infection, or you can say inflammation of the kidneys. Pyelo, it is so infection associated with infection. So first one is in glomerulonephritis and in pyelonephritis. In pyelonephritis, it is pyelo, it's infection. So there is toxic syndromes. So in toxic symptoms or syndrome, what we can see fever, headache, body pain, like these symptoms are called toxic syndrome. So we can see these in pyelonephritis. In glomerulonephritis, no toxic syndrome. Glomerulonephritis, it is mainly autoimmune process. This one is infection. As it is autoimmune, so it occurs bilaterally. Pyelonephritis is mainly unilateral. The mode of progression is, it is anterograde mainly. Anterograde means from throat to kidney, and it is mainly retrograde. So it is from associated with UTI, right? So it is associated with UTI. So from the ureter or urethra or bladder, we can have this infection. It is mainly associated with throat infection, mainly streptococcus. As we said before, it is UTI associated or cystitis associated, and the infection travels retrograde to kidney, right? Then We can see edema, hypertension here in glomerulonephritis. In pyelonephritis, it is rare. In glomerulonephritis, proteinuria is more than equal to 2 gram. Here it is really less than 2 gram. So these are the difference between glomerulonephritis and pyelonephritis. And now let's get back to the question. Here we have facial edema. Temperature is normal. We have BP. We have hematuria. Proteinuria is 2 and associated with acute tonsillitis. So we can see associated with it we have hypertension, we have throat infection, and there are also moderate back pains. So bilateral back pain. Then you have proteinuria of more than 2 and normal temperature, no toxic syndrome, right? So here is we have no toxic syndrome, no fever. So it suggests of glomerulonephritis. So acute pyelonephritis can be an answer. No cancer, no urolithiasis. So glomerulonephritis is an answer. But here we have acute and chronic. So we see the time. It is just after 2 weeks. So we call it acute glomerulonephritis. So for this video, I think that's enough. We will continue in our next